The task of distinguishing who is normal from those whose behavior may be considered abnormal is fundamental in psychology. The definition of abnormality plays a key role in determining whether someone is diagnosed mentally ill, and the diagnosis largely determines the treatment a patient receives. The line that divides normal from abnormal is not as clear as you may think. Rather, all behavior can be seen to lie on a continuum, with normal, or what may be called effective psychology function, at one end, and abnormal indicating a psychological disorder at the other, sane and insane. It is often up to mental health professionals to determine where on this continuum a particular person's behavior falls. To make this determination, clinical psychologists, psychiatrists, and other behavioral scientists and clinicals may use one or more of the following criteria. Context of the behavior. This is a subject judgment, but you know that some behaviors are clearly bizarre in a given situation. Persistence of behavior. We all have our crazy moments. A person may exhibit abnormal behavior on occasion without necessarily demonstrating the presence of mental illness. Social deviance. When a person's behavior radically violates society's expectation and norms. Subject distress. Frequently, we are aware of our own psychological difficulties and suffering they are causing us. When a person is so afraid of enclosed space that he or she cannot ride an elevator. Psychologically handicapped. When a person has a great difficulty being satisfied with life due to psychological problems. Effect on functioning. The extent to which the behavior in question interferes with the person's ability to live the life that he or she desires. Rosengren, a professor of Stanford, questioned whether the characteristics that led to psychological diagnosis reside in the patients themselves or in the situations and contexts in which the observers find the patient. He reasoned that if the established criteria and the training mental health professionals have received for diagnosing mental illness are adequate, then the professionals should be able to distinguish between the insane and the sane. Rosengren tested by requiring 8 patients, including himself, to serve as a pseudoid patients. The 8 patients consisted of 3 men and 5 women. All the pseudoid patients followed the same instructions. They called the hospital and made the appointments. Upon their arrival at the hospital, they complained of hearing voices and said empty, hollow, and thud. Other than this single symptom, all patients acted completely normal and gave truthful information to the interviewer. Upon completion of their intake interview, all the participants were admitted to the hospitals, and all but one was admitted with a diagnosis of schizophrenia. Once inside the hospital, the pseudoid patients dropped their pretend symptoms and behaved normally. The participants had no idea when they would be allowed to leave the hospital. It was up to them to gain their release by convincing the hospital staff that they were mentally healthy enough to be discharged. All the patients took notes of their experience. At first, they tried to console this activity. But soon it was clear that this scarcity was not unnecessary because hospital staff interpreted the note-taking behavior as another symptom of their illness. The goal of all pseudoid patients was to be released as soon as possible, so they behaved as model patients, cooperating with the staff and accepting all the medications, which they did not swallow but rather flushed down the toilet.
The length of the hospital stays for the pseudo patients ranged from 7 to 52 days, with an average of 19.
The key finding in this study was that not one of the pseudo patients was detected by anyone on the hospital staff.
When they were released, their mental health status was recorded in their files as schizophrenia in remission. They recorded other interesting findings and observations as well.
Although the hospital's staff of doctors, nurses, and attendants failed to detect the participants, the other patients cannot be fooled so easily. In 3 of the pseudo patients' hospitalizations, 35 out of 118 real patients voiced suspicions that the participants were not actually mentally ill.
Contacts among the patients and the staff were minimal and often bizarre. One of the tests the pseudo-patients initiated in the study was to approach various staff members and attempt to make verbal contact by asking common questions. Here we can see the responses by the doctors and staff to questions posed by the pseudo-patients. Often, the doctors then moved on without waiting for a response.
In contrast to a severe lack of personal contact in the hospital study, the patients received no storage of medications. The 8 pseudo-patients in this study were given a total of 2,100 pills that, as mentioned previously, were not swallowed.
Another anecdote from one of the pseudo-patients tells of a nurse who unbuttoned her uniform to adjust her bra in front of a day room full of male patients. It was not her intention to be provocative. According to the participants' reports, she simply did not consider the patients to be real people. Rosenhan's study demonstrated that even trained professionals often cannot distinguish the normal from the mentally ill in a hospital setting. This is because of the overwhelming influence of the psychiatric hospital setting on staff's judgment of an individual's behavior. Once patients are admitted to such a facility, the doctors and staff often tend to view them in ways that ignore them as such individual people. The attitude created is, if they are here, they must be crazy.
More important was what Rosenhan referred to as the stickiness of the diagnostic label. That is, when a patient is labeled as schizophrenic, that diagnosis becomes his or her central characteristic or personality trait. From the moment the label is given and the staff members know it, they perceive all of the patient's behavior as stemming from the diagnosis. Thus, the lack of concern or suspicion over the pseudo-patient's note-taking, which was perceived as just another behavioral manifestation of the psychological label.
Beyond this, a sticky diagnosis labeled even colored how a pseudo's patient's history would be interpreted. Remember, all the participants gave honest accounts of their past families. Following is an example of Rosenhan's research of a pseudo's patient's stated history, followed by interpretation by the staff's doctor in a report after participants were discharged. The participant's true history was as the following.
The pseudo-patient had a close relationship with his mother, but was rather remote with his father during his early childhood. During adolescence and beyond, however, his father became a very close friend while his relationship with his mother cooled. His present relationship with his wife was characteristically close and warm. Apart from occasional angry exchanges, friction was minimal. The children had rarely been spanked. The doctor's interpretation of this rather normal and innocuous history was as follows. This white 39-year-old male manifests a long history of considerable ambivalence in close relationships which begins in early childhood. A warm relationship with his mother cools during adolescence. A distant relationship with his father is described as becoming very intense. Affective stability is present. His attempts to control emotionality with his wife and children are punctuated by angry outbursts, and in the case of the children, spankings. And although he says he has several good friends, one senses considerable ambivalence embedded in those relationships also. Nothing indicates that any of the doctor's distortions were intentional. He believed in the diagnosis and interpreted a patient's history and behavior in ways that were consistent with that diagnosis. Rosenhan's studies shook the mental health profession. The results pointed out 2 crucial factors. First, it appeared that the sane cannot be distinguished from the insane in mental hospital settings. As Rosenhan himself stated in his article, the hospital itself imposes a special environment in which the meaning of behavior can be easily misunderstood. The consequences to patients hospitalized in such an environment seem undoubtedly counter-therapeutic. Second, Rosenhan demonstrated the danger of diagnostic labels. Once a person is labeled as having a certain psychological condition, that label eclipses any and all of his or her other characteristics. All behavior and personality characteristics are then seen as stemming from the disorder. The worst part of this sort of treatment is that it can become self-confirming. That is, if a person is treated in a certain way consistently over time, he or she may begin to behave that way. Out of Rosenhan's work grew greater care in diagnostic procedures and increased awareness of the dangers of applying labels to patients. This does not imply by any means that the mental health profession has eliminated labels. However, largely because of Rosenhan's research and other research in the same vein, psychiatric labels are now used more carefully and treated with the respect their power demands. However, other researchers dispute the conclusions Rosenhan drew from this research. Spitzer argued that although the methods used by Rosenhan appeared to invalidate psychological diagnostic systems, in reality they did not. For example, it should not be difficult for pseudopatients to lie their way into a mental hospital because many such admissions are based on verbal reports. Even though the doctor was tricked, Spitzer contended the diagnostic methods were not invalid. In addition, Spitzer has pointed out that although the pseudopatients behave normally once admitted to the hospital, such symptom variation in psychiatric disorders is common and does not mean that the staff was incompetent in failing to detect the deception.
The controversy over the validity of the psychological diagnosis that began with Rosenhan's 1973 article continues. Regardless of the ongoing debate, we can have little doubt that Rosenhan's study remains one of the most influential in the history of psychology. How do the people themselves feel who have been given a psychiatric diagnostic label? In a survey of more than 1,300 mental health consumers, Wall asked participants about their experiences of being discriminated against and stigmatized. The majority of the respondents reported feeling the effects of the stigma surrounding mental illness from various sources, including community members in general, family, church members, co-workers, and even mental health professionals. In addition, the author reported, the majority of the respondents tended to try to conceal their diagnosis and worry a great deal that others would find out about their psychiatric status and treat them unfavorably. They reported discouragement, hurt, anger, and lowered self-esteem as a result of their experiences, and urged public education as a means for reducing stigma. Mental health professionals hope that we, as a culture, will increase our tolerance and understanding of psychological disorders. As we do, our ability to diagnose these disorders will continue to improve, although in many cases it continues to be as much as an art and science. Chances are we will never do away with psychiatric labels. They are an important part of effective treatment of psychological disorders, just as names of diseases are a part of diagnosing and treating physical illnesses. However, if we are stuck with labels, we must continue to work together to take the stigma, embarrassment, and shame out of them. If you would like more information or resources on mental health, visit the National Institute of Mental Health website at www.nimh.nih.gov.